Welcome to the Concierge Care Health System podcast. The information shared in this podcast is for general informational purposes only and does not constitute medical advice. Listeners should be aware the content is not a substitute for professional medical advice, diagnosis, or treatment. Always consult with a physician or other qualified healthcare provider for medical questions.
Imagine this scenario. You've been dealing with depression, feeling pretty overwhelmed, maybe really isolated. You finally take that big step, reach out for help, you get a prescription for an antidepressant, and you feel that glimmer of hope. But then you start maybe feeling a bit better mentally. You notice something else. A really crucial part of your life has been, well, unexpectedly and pretty profoundly impacted. Welcome to the Deep Dive. Today we're taking a deep dive into your sources about something really important and honestly often overlooked. How antidepressants, especially the common ones, uniquely affect sexual function in females. And this spans from adult women right through to adolescent girls. Our mission today is to really unpack the science behind this, understand the real-world impact it has, and maybe explore some pathways towards better care. So if you've ever taken antidepressants or thought about it, or maybe you care about someone who has, this deep dive is going to offer some vital insights. We want to show you why understanding the how and the why of these medications is just essential for your well-being and for a better quality of life. This isn't, just some minor side effect. It touches on a really fundamental aspect of human experience. So let's kind of set the stage here. When we look at the big picture of depression, the data, well, it clearly shows that major depressive disorder, MDD, it hits females harder. And what really jumped out at me from the sources was that this isn't just something affecting adults. No, this difference starts showing up shockingly early, like in adolescence. Girls are nearly 3 times as likely as boys to have a major depressive episode by the time they're teenagers. Some recent data is pretty stark too. 1 in 5 adolescent girls, that's 20%, had at least one major depressive episode in the past year. And get this, that rate jumped by 37% over the last decade. So it means females, especially young women and girls, are the main people receiving these antidepressant medications.
Right, and that creates a really, a particularly difficult situation for clinicians because, you see, sexual dysfunction, it isn't just a potential side effect of the medicine, it's also a very common symptom of untreated depression itself. The sources suggest over 70% of people with untreated depression report some kind of impairment in that area.
Wow, over 70%, that's huge.
It is. And connecting this to the bigger picture, it makes it incredibly challenging for doctors to figure out, okay, are these new sexual difficulties maybe leftover symptoms of the depression, or are they something entirely new, what we call antidepressant-induced sexual dysfunction, or ASD? And here's the kicker. ASD can then sort of layer on top of any existing issues, creating what one source called a pernicious negative feedback loop.
A feedback loop, how so?
Well, imagine the treatment that's supposed to improve your overall well-being inadvertently starts undermining your quality of life, your intimacy, things that are actually really crucial for recovering from depression in the first place. The real catch-22.
That sounds incredibly difficult to navigate, both for the patient and the doctor. So if we focus in on ASD itself, that medication-induced part, why is it such a significant risk? What are we really talking about when it happens?
Exactly. It's a very real and frankly often under-discussed risk that we absolutely need to understand better.
Okay, let's dig into this then. To understand why different antidepressants have such different effects on sexual function, we need to look at the main classes your sources mentioned. First up, we have the SSRIs, the selective serotonin reuptake inhibitors. These are probably the names you recognize.
Yeah.
Fluoxetine, sertraline, paroxetine, citalopram, acetalopram. So how do they work?
Well, they work by blocking the reuptake of serotonin, basically stopping it from being reabsorbed too quickly. This means you get significantly more serotonin hanging around in the synapses in your brain. And this potent and selective serotonergic enhancement, as the sources put it, well, it's linked both to why they work for depression, but also, crucially, to their side effects.
Right. Okay. So that's SSRIs. Then you mentioned SNRIs. Serotonin norepinephrine reuptake inhibitors, like venlafaxine, duloxetine.
Exactly. These have a dual mechanism. They block the reuptake of both serotonin and norepinephrine. But an important point here, especially at lower doses, the serotonin effect often tends to dominate, which means their impact on sexual function can often look pretty similar to the SSRIs.
Okay. And then the third group, which you said was really distinct, the NDRIs. norepinephrine dopamine reuptake inhibitors, and the main one here is Bupropion.
That's the one, Bupropion. Its mechanism is quite different. It inhibits norepinephrine and, importantly, dopamine reuptake. But it has minimal, maybe even no significant effect on serotonin.
So no serotonin effect. That seems key.
It's absolutely fundamental to why its side effect profile, especially sexually, is so different. And what's really fascinating here is how these different drug actions, bump up against the brain's own chemistry for sexual function. Think of it like this. Serotonin, or 5-HT, generally acts as an inhibitor when it comes to sex. So when you artificially elevate serotonin levels with medication, it's consistently linked to things like decreased libido, difficulty or delay in reaching orgasm, even a kind of emotional flatness or blunting.
Okay, so serotonin generally means brakes on. What about the others?
Well, in direct contrast, you have dopamine, or DA. That's a primary excitatory neurotransmitter for sexual function. It's really central to motivation, pleasure, that feeling of desire, the wanting part. Dopamine helps facilitate arousal and orgasm, so generally things that boost dopamine tend to be pro-sexual.
Right, dopamine is more like the go signal.
You could say that. And then there's norepinephrine, or NE. It's a bit more complex, kind of a dual role. It's involved in alertness, focus, general arousal, and also physiological stuff like clitoral erection and orgasm. But, and this is important, too much NE can actually trigger anxiety, which, as you can imagine, is pretty counterproductive for sexual response. So you need a kind of Goldilocks level just right.
So putting all that brain chemistry together, the SSRIs and SNRIs, by boosting serotonin so much, are essentially creating this serotonin dominance. And that directly kind of suppresses or interferes with the dopamine and norepinephrine pathways that we need for healthy sexual function.
That's the fundamental conflict, yes. The predictable pharmacology points right to that suppression.
Whereas the NDRIs, like Bupropion, they enhance the prosexual dopamine and norepinephrine systems, but they leave that inhibitory serotonin system pretty much alone.
Exactly. And that's why their sexual side effect profiles are just dramatically different. It really boils down to that neurochemical clash.
So what does this clash look like in reality? How common is this problem with the SSRIs and SNRIs?
Well, the reality is pre-Stark, those early drug trials, they often really underestimated the rates of sexual dysfunction, probably because of how they asked about it or didn't ask. But when you look at studies that directly ask patients, and especially meta-analyses combining multiple studies, you see a much harsher picture. We're talking anywhere from 25% up to, believe it or not, 80% of patients experiencing some form of sexual dysfunction on these meds.
80%? That's astonishingly high compared to placebo.
Compared to about 14% with placebo. So yes, it's a massive difference. It's clearly linked to the medication's action.
And what kind of symptoms are we talking about specifically in females?
It's quite a broad range and frankly pretty distressing for the people experiencing them. Decreased sexual desire or libido, that's very common, affecting up to 72% in some studies.
Okay.
Then there are arousal difficulties. Things like diminished genital sensitivity or problems with vaginal lubrication reported by as many as 83% of women in some cohorts. And then, of course, anorgasmia, the inability to reach orgasm or it being significantly delayed, that affects around 42%. And less common, but really impactful. Some women report actual genital numbness or what's been termed pleasureless orgasm.
Pleasureless orgasm. That sounds awful. It really seems to rob people of something fundamental.
It really does. It profoundly impacts quality of life and intimacy.
And you mentioned earlier some drugs are worse than others. There's a hierarchy of risk.
Yes, the sources consistently point to this. Paroxetine, brand name Paxil, seems to be at the top of the list, highest risk for sexual side effects. It's often followed by the SNRI venlafaxine or Effexor XR, and then other common SSRIs like citalopram, escitalopram, sertraline, fluoxetine, duloxetine, Cymbalta seems to be intermediate in risk.
So that ranking really lines up with the idea that it's linked to how strongly they affect serotonin.
It reinforces that connection quite clearly. More potent serotonin action generally equals higher risk. But here's where things get, well, truly sobering. The most alarming potential risk linked to these serotonergic antidepressants is a condition called Post-SSRI Sexual Dysfunction, PSSD.
Post-SSRI, meaning after you stop taking them.
Exactly. This is where sexual side effects, and often severe ones like genital anesthesia, that pleasureless orgasm, persistent loss of libido, they continue indefinitely after the person has stopped the medication. We're talking potentially for months, years, or possibly even permanently. It causes profound, lasting distress for those affected.
Permanently. That's terrifying. How common is this PSSD?
That's part of the problem. It's poorly understood and seems to be severely underreported. But there are growing numbers of case reports, significant patient advocacy, and regulatory bodies are starting to take notice. For instance, Australia's Therapeutic Goods Administration, the TGA, they've updated warnings about the risk of long-lasting sexual dysfunction that continues even after stopping the drug.
So this isn't just theoretical.
Not at all. It means that prescribing an SSRI or SNRI isn't just a matter of managing potentially reversible side effects. There's a small but real and potentially devastating risk of inducing a permanent injury to someone's sexual function. And this obviously significantly elevates the ethical and clinical stakes, especially when we're talking about prescribing these to younger patients, adolescents, whose sexual and neurological systems are still developing.
That is a heavy consideration.
Yeah.
Okay, so that's the high-risk side of the picture. But you mentioned there's also, thankfully, a beacon of hope. There are other effective antidepressants with a much lower risk profile.
Yes, absolutely. And this is crucial information.
So let's talk about Bupropion again, the NDRI. You said it consistently comes out with the lowest risk.
That's right. Its risk of sexual side effects is often comparable to placebo. Remember those high numbers for SSRIs, like 58, 73%? For Bupropion, the estimates are much, much lower, maybe 10, 25%.
And that's because of its mechanism, right?
Yeah.
Enhancing dopamine.
Exactly. It boosts dopamine, which, as we discussed, is key for desire and pleasure. It actually aligns with the neurobiology of sexual excitation, rather than fighting against it. In fact, some studies even suggest it might heighten sexual functioning, sometimes even beyond where the person was before their depression.
Wow, so it could potentially improve things.
It's a possibility. This makes Bupropion a really critical tool, not just as a first-choice antidepressant for some, but potentially even as an antidote strategy if someone develops AIS on another medication.
An antidote.
Yeah.
We'll come back to that. Are there other lower-risk options besides Bupropion?
Yes, there are. Newer, what are called multimodal agents, have also shown significant promise. Vortioxetine, the brand name is Trintellix, it's demonstrated a significantly lower risk of causing sexual dysfunction compared to potent SSRIs. There was one major study, quite impressive actually, where they switched patients who had SSRI-induced sexual dysfunction over to vortioxetine. 84% of them reported improvement, and 43% said their sexual function was greatly improved.
That's a huge improvement.
It really is. And similarly, vilazodone or Vibrade, which has a slightly different combined mechanism, it also seems to have a more favorable profile than the traditional SSRIs. So yes, there are definitely alternatives.
Okay, so putting this all together, the fact that these effective, lower-risk antidepressants exist, it really challenges that inertia you sometimes see, right? That sort of reflexive prescription of high-risk SSRIs as the default first step for everyone.
Absolutely. It challenges that clinical inertia.
It seems like for someone who's sexually active or just really values that aspect of their life, starting with one of these lower-risk options like Bupropion or vortioxetine might be a much more patient-centered approach.
Precisely. It could potentially improve not just adherence to treatment, because side effects are a major reason people stop meds, but also their overall quality of life during recovery. Seems logical looking at the evidence.
Makes sense. Now, we touched on adolescence earlier, and you mentioned the stakes are even higher there. Can you elaborate on that?
Yes, while AIS is a serious issue for adults, the implications for adolescents are, well, deeply concerning, partly because we know so much less. There's what the sources call a critical and widely acknowledged gap in the research. Most studies on AIS, they're done in adults. The few involving teens often use really unreliable methods, like just waiting for them to spontaneously report a problem.
Which teenagers are probably unlikely to do.
Exactly. Leading to, frankly, unbelievable results, like one large study of over 2,000 adolescents on SSRIs reporting 0 cases of sexual dysfunction. That finding is so wildly out of step with adult data, it almost certainly reflects poor detection methods, not a true lack of effect.
And this lack of data is especially worrying because...
Because adolescent girls are one of the fastest growing groups being prescribed these very medications. We're potentially exposing a vulnerable population to risks we don't fully understand.
And you mentioned the impact on development.
Right. Adolescence is this incredibly critical and formative period for developing your sexual identity, your self-concept, learning about relationships and intimacy. Now imagine putting a medication into that mix that can cause things like genital numbness, inability to orgasm, complete loss of libido, or just general emotional flatness. It can, as one source put it, literally rob an adolescent of the ability to experience and learn about their own sexuality in a normal, healthy way.
That's a chilling thought.
Yeah.
You mentioned anecdotal reports.
Yes, really poignant ones. Young adults looking back saying things like, they had no idea what an orgasm was until they stopped the antidepressant they'd been taking since their teens.
Oh, wow.
And layered on top of this is the risk of PSSD, that persistent dysfunction. In an adolescent, that would be a truly catastrophic outcome. And the terrifying part is we just don't know the true risk level in that age group because the research hasn't been properly done.
So given all these risks, particularly the unknown ones and the potential for lifelong impact, what does this mean for getting consent from teenagers?
It means the ethical bar for informed consent has to be set exceptionally high. It is absolutely not enough for a doctor to just tick a box saying sexual side effects discussed.
There's a real professional duty here to have a proactive, detailed, very clear conversation. With both the adolescent and their parents or guardians, this conversation needs to cover the specific types of dysfunction. Low libido, orgasm problems, numbness, and their high probability based on adult data. And crucially, it must include the known, even if considered rare, risk of persistent or permanent problems like PSSD.
Without that level of detail, it's not really informed consent at all.
Exactly. Without that transparency, you really have to question if we're upholding that fundamental principle of medicine, primum non nocere. First, do no harm.
Okay, so let's shift to management. If someone is experiencing ASD, what should clinicians be doing? It sounds like the first step happens even before starting the medication. That's right. The foundation for good management starts pre-treatment. It is clinically vital, really imperative, to do a baseline assessment of sexual function before the patient even starts taking an antidepressant.
Why is that so important?
Because, as we said, depression itself can cause sexual dysfunction. Without knowing the baseline, how can you possibly tell if a problem that emerges later is due to the medication, or if it was already there, or maybe it's a mix of both? You're just guessing otherwise.
Makes sense. Good starting point.
Yeah.
And then, once treatment begins.
Then clinicians need to adopt what the sources call systematic monitoring. This means proactively asking about sexual function at every follow-up visit.
Proactively, meaning don't wait for the patient to bring it up.
Precisely. Patients are often really hesitant to talk about these things spontaneously, embarrassment, not wanting to complain, thinking it's just part of the depression. Lots of reasons. So simple, direct, non-judgmental questions are key. Things like, have you noticed any changes in your sexual desire or function since starting the medication? Using validated questionnaires like the ASEX or CSFQ can also help track things more objectively.
Okay, so baseline assessment, then systematic proactive monitoring. What if ASD is identified and it's causing distress? What are the treatment strategies?
Well, there's a pretty clear hierarchy based on the evidence. Some things are generally not recommended, like just watchful waiting, hoping it goes away on its own. Most cases don't resolve spontaneously. And drug holidays, skipping doses before sex, that carries high risk of withdrawal or depressive relapse, so definitely not advised. Reducing the dose might help sometimes, but again, you risk the depression coming back.
So those aren't great options. What is recommended?
The primary and generally most effective strategy is switching antidepressants. But the crucial principle here is you don't switch from one high-risk SSRI to another high-risk SSRI or SNRI. Their mechanisms are too similar, you likely won't see much improvement.
Right, that wouldn't make much sense.
No. The evidence-based approach is to switch from that high serotonin drug to one with a lower risk mechanism. So switching to bupropion or mirtazapine or vortioxetine, that's generally the first line of pharmacological attack.
Okay, switching is plan A. What if someone is doing really well on their current antidepressant, depression-wise, and doesn't want to switch? Is there a plan B?
Yes, that's where augmentation therapy comes in. This means adding a second medication specifically to counteract the sexual side effects of the first one. Kind of like that antidote idea we mentioned.
And what works best for augmentation?
The strategy with the most robust evidence, by far, is adding bupropion. Multiple good quality trials, randomized controlled trials, show that adding bupropion, say 150 milligrams of the sustained release form twice a day to an ongoing SSRI or SNRI significantly improves desire, arousal, and orgasm in women.
So bupropion can be used both as a primary treatment and as an add-on.
Exactly. It's quite versatile. Sildenafil, Viagra, has pretty mixed evidence for women. It might help a bit with arousal or orgasm for some, but generally not desire, so it's not considered first line. And other agents sometimes mentioned, like bupropion or amantadine, they really lack strong supporting evidence for this purpose. Bupropion is the clear standout for augmentation.
Got it. So switching first or augmenting with bupropion if switching isn't ideal, are there non-drug approaches that can help too?
Definitely. Behavioral and complementary interventions can be valuable tools. There's actually strong evidence for targeted exercise.
Exercise, how does that work?
Specifically, doing about 30 minutes of combined cardio and strength training right before planned sexual activity. Studies have shown this can significantly boost arousal and overall sexual function in women taking SSRIs. It's like priming the system.
Interesting, like a little pregame warm-up.
Kind of, yeah. And psychotherapy and education are also vital. Just helping patients understand that ASE is a real physiological side effect, not their fault, not a sign of relationship problems, can reduce a lot of self-blame and distress. Sex therapy can also offer coping strategies and improve communication with partners.
That makes sense. What about complementary therapies? You sometimes hear about herbs or supplements.
There's some preliminary evidence for a few things, like maca root, saffron, and something called rosa damascena oil. Some small studies suggest they might help in specific areas like desire or arousal, but honestly, much more rigorous research is needed before these can be widely recommended. They're not quite ready for prime time yet.
Okay, so bringing this all together, synthesizing these findings, what's the big picture takeaway?
I think the big picture is that these profound differences we see in the sexual side effects of various antidepressants, they aren't random. They're a direct, predictable result of how these drugs work at a fundamental level, their pharmacology. There's a core conflict between the brain chemistry needed for healthy female sexual response driven by dopamine and norepinephrine inhibited by serotonin and the action of our most prescribed antidepressants, the SSRIs and SNRIs, which crank up serotonin. And the consequences are significant. High rates of ASE, this alarming risk of PSSD, it's a real public health issue. It affects whether people stick with treatment, it damages quality of life, and perhaps most disturbingly, it has the potential to disrupt the healthy psychosexual development of young people.
It really sounds like this calls for a significant shift in how we approach prescribing these medications. So, for you listening, what does this all mean? What are the key messages to take away from this deep dive? Well, first, the idea of patient-centered prescribing seems absolutely crucial. The choice of which antidepressant to start with really should explicitly factor in things like your age, your relationship status, whether you're sexually active, and frankly, how important sexual function is to you personally. These factors need to be weighed against the known risk profiles of the different drugs. Maybe for a young, sexually active person, starting with a high-risk SSRI isn't the best first choice. Perhaps bupropion or another lower-risk agent would be a more logical place to begin. It's about tailoring the treatment to the whole person, not just the depression score.
Absolutely. It's about fitting the treatment to the individual's life and priorities.
Second, it seems clear we need to elevate bupropion in the treatment algorithm. Given its effectiveness for depression and its uniquely favorable sexual side effect profile, there's a strong argument for considering it a first-line agent much more often, particularly for anyone who prioritizes maintaining their sexual function. It seems like an invaluable and maybe underutilized tool.
It certainly appears underutilized based on prescribing patterns versus its profile, yes.
And third, we absolutely have to raise the standard for informed consent. That conversation between doctor and patient, especially with adolescents and their guardians, needs to be truly transparent and detailed. It needs to acknowledge the high likelihood of specific side effects like low desire or orgasm problems, and it must include the recognized, albeit perhaps rare, risk of persistent or permanent sexual dysfunction, PSSD. This is fundamental for true shared decision-making.
Couldn't agree more. That transparency is paramount. So this deep dive highlights what we currently understand, but it also shines a light on significant gaps, doesn't it? It leaves us with some important questions to ponder. How can we, as a society, ensure that future research on antidepressants, especially research involving women and adolescents, genuinely prioritizes understanding the impacts on sexual health and long-term well-being? It can't be an afterthought anymore. And perhaps more personally for you listening, what steps can you take to advocate for a truly patient-centered approach in your own healthcare? How can you ensure that your holistic well-being, including your sexual health, is considered a core, non-negotiable component of your recovery journey? Something to think about.
Concierge Care, providing world-class, personalized care for patients and members. Taking a proactive approach by offering its free digital health clinic for anyone in need of these services. Reach out to us via our website, www.health.conciergecare.net, or give us a phone call at 786-809-2821. 2, 3, 4, 5.